We also see in that data set that people present for problems to be managed at higher rates for psychological reasons when they have intellectual disability. And we see that GPs are overwhelmed with mainly administrative reasons for presentation rather than medical needs. Now this results in an underemphasis of preventative health care. So we see in the data sets that GPs simply don't get to the preventative health screening for this population, and they prescribe lower rates of preventative health medicines for the group as a result. Things that we may need to control our risk factors for cardiometabolic diseases later in life, attention to screening for cancers and so forth. These are lower in people with intellectual disability. And we see, not surprisingly, that there are much higher rates of recommendation for psychotropic medication treatment. And one statistic that stands out is the tenfold higher rates of recommendations for antipsychotic treatment for this group, which doesn't really match the known increase in prevalence of mental disorders, but is quite a substantial finding. Another really interesting signal is a signal we're getting when we look at whether people with intellectual disability are known to services. We've looked at the public mental health service system data and looked at contact in the preceding year. So when someone comes into a service, were they known to that service in the preceding year? To try and get a sense of, if we were to address the needs of a population, would it have an impact on later service provision? When we've looked at all people in the mental health service system data set, about half of people presenting in any given time were known in the previous year. Only about half. When we look at whether they were known to inpatient mental health services, the rate is about 46%. When we look at people with intellectual disability, we see a different story. This is a more stable population, a population that is known at a local level. And we see that 2/3 of people were known to services in the year preceding their contact with mental health services. And in fact, 70% of them were known to inpatient mental health care. We also looked at what happens to some aspects of trajectory through a system. We looked at whether provision of community mental health supports potentially reduces length of stay, to give us some sense of, well, if we were going to do something to support people with intellectual disability in the service system, what could that look like? And would better provision of more cohesive community care make a difference? We saw in our data set at an LHD level that more minutes of clinical care in non-inpatient services reduced admission length 3 months later. We also saw that at an individual level, non-inpatient care following an admission reduces subsequent admission length. So these are some things that help perhaps shape our views on what to do next. So just to recap this part of the data story, we identified about 1% of the New South Wales population as having intellectual disability. We saw that they were overrepresented in all of the health data sets, but especially so for mental health. We saw that people with intellectual disability accessed similar amounts of non-inpatient mental health care as all people using the services, but we saw that people with intellectual disability experienced much longer inpatient mental health stays, and this is what determines the higher overall costs. We also saw that there are markers of different patterns in mental health care, and we saw some pointers for improvements in care, potentially. So what could we do? Well, I want to present some relative costings of a simplified LHD-based intellectual disability mental health service model here. I'm not saying this is my preferred model, I'm just using this template as a template for costing. So what we've done is just developed a simplified intellectual disability mental health team model for illustrative purposes and looked at the costs of that in the corresponding financial year from which the data you just saw was drawn. And what we've done is configured here 2 teams, both that roughly cost the same amount. One with flat 1.0 full-time equivalent psychiatrist, registrar and nurse practitioner, and another one with a fractional psychiatrist, so 2 nurse practitioners. And that helps us think about what they can do. Where should such a service focus its efforts? Well, non-inpatient care setting, it could focus its efforts on reviewing complex cases, reviewing those at risk of admission, It could ensure adequate post-discharge follow-up to try and reduce some of those representations. At admission, it could look at people with their first ever presentations and how do we do it better for those people. It could look at reviewing most admissions because we can see a value in coordinating care around that person by understanding their needs more thoroughly at the beginning of the admission. In emergency department, it could support all emergency department staff, and it could try and address some of the issues where there's a mental health or behavioural or situational crisis presenting. And it could provide a training and equipping role for the LHD. So at a cost level, at an LHD, metro, regional and state level, this is what such a service would cost in that financial year. At an LHD level, a very modest $566,000. At a total state level, about $9.6 million, which at first glance sounds like a lot. But let's look at the overall spending on people with intellectual disability in the mental health service system in New South Wales. We can see that the overall spending on this group is in fact currently about $143 million. So in comparison, $9.6 million is a drop in the ocean. In fact, you can work out the percentage, it's about 8.6%. And in fact, that cost is quite a bit lower than the value of a 10% reduction in length of stay for that group. So we've costed that there at the bottom, the value of a 10% reduction in New South Wales for people with intellectual disability only. A 10% reduction in their length of stay is over $12 million. So the comparative costs and just a ballpark efficiency, if you like, is more than